All right. Well, good evening, everyone. I know there will be participants joining throughout the next minute or two, but we're excited that you are here for our webinar, for the Ask the Experts webinar series. And tonight's topic is understanding bladder cancer symptoms, diagnosis, and treatment advances. It's going to be a great presentation, and you'll have an opportunity to ask questions at the end of the webinar. Just a little bit about how to navigate things this evening. If you have a question at any time during the presentation, just go ahead and look at the very bottom of your screen, and there is a Q&A button. You'll simply click on that and enter your question, and we will be sure to answer those at the end of the presentation this evening. And then as we close out tonight, you will have a very short survey that will pop up. If you'll take a moment to just provide a few answers for us there, we'd really appreciate it. That just helps us to be able to offer topics that you are most interested in. All right. Well, I want to take a moment to introduce Dr. Shatagopam, and he is our presenter and expert tonight. He is a board certified urologist with Urology Austin, and he trained at Indiana University. He specializes in comprehensive and minimally invasive urologic care for both men and women. Dr. Shatagopam also holds expertise in BPH treatment, kidney stones, erectile dysfunction, low testosterone, urinary incontinence, and other urologic conditions affecting both men and women today. In addition, he is extensively trained in minimally invasive robotic and laparoscopic surgery for the management of urologic cancers of the kidney, prostate, testes, and bladder. And tonight, he'll be covering that exact topic, so helping us to understand more about bladder cancer. So Dr. Shatagopam, we're excited that you're here tonight, excited for the presentation, and I'll pass it over to you.
Excellent. Thank you so much, Jamie, for the introduction. Hello, everyone. First of all, thank you for taking the time out of your evening to join us for this, hopefully quick but informative, educational presentation about bladder cancer. Before I go forward, if any of you are college football fans, I'm sure you've realized that Indiana University won the national championship this year. So go Hoosiers. Just wanted to say that. And everything else that Jamie said, I appreciate that. And we'll get started. And like she said, any questions, anything at all that you can think of along the way, just write them down, send them over to us, and we'll do our best to answer it at the very end. All right. So bladder cancer, just understanding it, it's one of the most common urological cancers. The problem is, early symptoms such as blood in the urine, and, changes in your urinary frequency, urgency, just habits in general, they're often overlooked, they're ignored. A lot of people, may have a little symptom here or there, and, they just tend to overlook it, which can lead to serious things down the road. Bladder cancer, it begins in the lining of the bladder, which, as you all know, is the organ that stores urine. And it's one of the most common cancers of the urinary system. And like we briefly discussed, the most common early sign is blood in the urine. Whether it's painful or painless, it's something that certainly should set off a red flag. And I want to highlight the point that if detected early, when bladder cancer is detected early, it's highly treatable. So, absolutely very, very important to pay attention to. This is just a quick schematic on the left here. I'm not sure if you can see my mouse, but this is a male. If you take a cross section right through the center of their body and look at it from the side, the structure sitting kind of right below the bladder is the prostate, has a couple of lobes. There's a kind of a tube that goes right through it. That's the urethra, where we all urinate from, whether you're a male or a female. And then the structure right on top, right behind the pubic bone and right on top of the prostate in a male is the bladder. And you can kind of see this little abnormal structure here, which would be a bladder tumor. If you look on the right side, that's a real view of an inside of a bladder with the patient with bladder cancer. And the fluffy kind of lesion right in the center of the picture is the bladder tumor, and that's a pretty characteristic picture of most bladder tumors. Now, not all bladder cancer is the same, not all of it looks the same, but this is a pretty characteristic picture of what we as urologists can expect to see when we find something of note in a patient with bladder cancer. And we'll talk a little bit more about that in the subsequent slides. Let's talk about some common symptoms and risk factors that are associated with bladder cancer. The theme of the day is going to be blood in the urine, and that's the most important thing. So, just to take a step back, once again, bladder cancer, statistically, it's the fourth most common cancer in men, and globally, worldwide, it's about the ninth most common cancer overall. It's increasingly more prevalent in males compared to females, with a male to female ratio of about 4 to 1. And then, not surprisingly, the older you get, there's an increased incidence with age in terms of developing bladder cancer. As you can see here, blood in the urine, we also call that hematuria. That's the medical name for it. That's the most common presenting symptom in patients with bladder cancer. It can range from a single drop to something that looks pink, like pink lemonade. It could look like wine red. Some people can pass clots, and there's just so many different ways that hematuria can present. And hematuria can come in two forms. The two broad categories are macroscopic or microscopic. For macroscopic, the other word would be considered gross. So gross hematuria is when you can visibly see blood in the urine to the naked eye. And that's the most concerning symptom. And if you look at all patients that are being diagnosed with bladder cancer, up to 35 to 40% of them will have gross hematuria. So anyone at any point, if you, your family members, anyone that notices any degree of gross hematuria or visible blood in the urine, the first thing they should do is give us a call so we can get you in to be evaluated. On the other end, the other type of hematuria is called microscopic hematuria. And that's people that have blood in the urine, but it's not apparent to the naked eye. And the only way that it gets picked up is if we do tests in the office. If there's any of my patients on this webinar, you probably know that when you come into the office, if you're a new patient, almost 100% of the time, we check a urine sample, whether you're having any symptoms or not, as part of just an initial screening. We have special urinalysis tests where we, if anything looks concerning, we further evaluate that under the microscope. And there's a certain threshold of red blood cells that you're able to see. And if you meet that threshold, then it's automatically flagged, and you'll probably get a call from us saying, hey, we found some microscopic red blood cells. They meet a certain threshold. We should do some further evaluation. And if you're an established patient, as you know, we'll probably collect urine samples from you at most visits. So it's an invaluable initial test in patients that are otherwise asymptomatic. And the reason this is important is, although it's much less common to have bladder cancer in patients with asymptomatic microscopic blood in the urine, if you look at the numbers in patients being diagnosed with bladder cancer, up to 10% of them will have microscopic hematuria. So it's not something that needs to be ignored. And I'll also see a lot of my patients who are referred to me from primary care doctors. They usually, I believe, once a year, as part of your annual examination, they'll do a urinalysis. If anything looks concerning, they send you guys right to me. So very, very important test. Other symptoms that are very common, irritative voiding symptoms. What does that mean? Think of increased urinary frequency. You're having to go a lot more. Increased urgency of urination, burning with urination. Now, you might be thinking these are pretty common symptoms with urinary tract infections, which is true, but nevertheless does require evaluation. And if these symptoms, are present, we should certainly do urine evaluations. And if there's any evidence of blood, then we'll talk about what all tests and things we need to do to further manage this. Other symptoms that are less common but can be seen in patients with more advanced stages of bladder cancer would be things like pelvic pain or back pain. And typically, these type of symptoms will present if you're presenting at a very advanced stage, meaning the bladder cancer has started growing through the bladder wall and kind of involving some of the surrounding structures. Sometimes the bladder cancer can block the tubes that drain the kidneys into the bladder. That causes swelling of the kidneys or hydronephrosis. And that can also lead to back pain. But those symptoms typically are seen in later stages, but still, nonetheless, should not be ignored. Let's talk about some risk factors for bladder cancer. The number one risk factor is tobacco exposure. There's no other way to sugarcoat it, but smoking, is the largest preventable risk factor for bladder cancer. Statistically, I would say about 50 to 60% of bladder cancer cases are caused by smoking. So it's a very, very significant amount. And that's whether you're a current smoker, former smoker, all of those increase your risk of developing bladder cancer. Smoking cessation is a strong recommendation across, just in terms of just general day-to-day life. There are certain occupational or chemical exposures that can predispose you to developing bladder cancer later in life. Patients that have had pelvic radiation for other types of cancers, such as uterine cancer, endometrial cancer. There's lots of other things where radiation therapy to the pelvic area, because that's where the bladder is, can increase your risk for developing bladder cancer later in life. Other things, chronic inflammation. So think of patients that have neurogenic bladders, that can't empty their bladder on their own, that have chronic catheters, that indwelling foreign object will lead to chronic inflammation and can set you up for certain types of bladder cancers. Not to go into more detail, but there's a few known mutations and chromosomal abnormalities that are seen commonly in patients that have bladder cancer. There are some genetic syndromes that also have a slightly increased risk of developing bladder cancer. So family history is also very, very important. Let's talk about diagnosis and staging. This is probably the most important thing to kind of decide which pathway a specific patient needs to go down. So, imagine you're a patient, if you had blood in the urine, whether it's gross hematuria or it's microscopic, it's going to warrant evaluation. Step one, the most common thing is we do additional urine testing. And the most commonly used test is something called a cytology, which some of you may have heard of. And that's basically looking for any sort of malignant or cancerous cells in the urine. It doesn't pick up all cancers, but if the cytology comes back positive, then it's certainly a concerning finding and definitely warrants further evaluation. Bladder cancer can arise, we talked about how it arises from the urine line cells. You have urine line cells in the kidneys, in the ureters, which are the tubes that drain the kidneys, the bladder itself, and the urethra. So anywhere from the kidneys all the way to the end of the urethra. So any patient that presents with blood in the urine, we have to do a full evaluation of the urinary tract. So typically this is done with something called a CT scan, which many of you may have had done for other reasons. But we typically do something called a CT urogram, which is a special fancy term for they give you some intravenous contrast and they take various pictures of your kidneys at different time frames. And what we're trying to look for is there anything in the upper urinary tract? So the kidneys and the ureters are considered the upper urinary tract. Is there anything in the kidneys or the ureters that would potentially lead to causing blood in the urine? It could be a kidney tumor, it could be a tumor of the ureters, but we do incidentally find benign causes of blood in the urine, so things like kidney stones. So that's an absolute mandatory thing. Some form of upper tract urinary imaging is typically done with a CT scan. by and far the most important test, which a lot of patients may be hesitant to undergo, is called a cystoscopy. It's where we take a little small camera scope in the office. We do this awake most of the time, just because it's a very simple procedure, and we like to avoid taking you to the operating room for a 30-second procedure to minimize some of those risks. But a cystoscopy, typically takes anywhere from 30 to 45 seconds, maybe a little bit longer if you need to get a better look inside the bladder. But it's done in the office. We instill some lidocaine jelly in the urethra, male or female. You're awake for it. We have a special uh, monitor system where we both can look at the monitor as we're doing it. So, some patients like to see what's going on. And unfortunately, this is the only good way to fully evaluate and visualize the inside of the bladder. Sometimes, if you have a large bladder tumor, that can sometimes be picked up on a CT scan, but not always. So the cystoscopy is the most important test. So three things that are typically done anytime a patient presents with blood in the urine is some form of urine testing, imaging of the kidneys, and the cystoscopy to evaluate the bladder. And then step four, if we do find a bladder tumor, and we'll talk a little bit about this in the upcoming slides, you will need something done under anesthesia in the operating room, either at a surgery center or a hospital. And that's where we would do some biopsies and sample the tissue to figure out, is this a bladder cancer, which in most cases is. And then once you have a diagnosis of bladder cancer, this is just kind of a precursor to, we'll talk a little bit more in the upcoming slides, but in general, bladder cancer is kind of categorized into muscle invasive, non-muscle invasive, and then advanced metastatic. That means it's spread beyond the bladder. And non-muscle invasive and muscle invasive, that's a big distinction because that kind of determines what sort of treatment may be recommended for you by your urologist. So here, just a couple of pictures. On the left half of the screen, the leftmost picture is a male bladder, and you know that because there's this little structure right below it called the prostate. And this is a general picture of what a cystoscope looks like. That's that flexible scope. It's the size of a small catheter. A lot of you may have had catheters or had family members with catheters. It's a small flexible tube with a little camera on it, and we basically just use it to go, into the urethra and into the bladder. And on the middle, you can see the female urethra is much shorter. Females tend to tolerate the procedure a little bit better, only because their urethra is a little bit smaller. But overall, it's a very simple and quick procedure that we do in the office. If you look at the right hand of the screen on the top, it's a picture of what inside of a normal bladder would look like through a cystoscope. And this is something that you would see on our monitors in the office as we're doing it. So on the top right, that would be a normal bladder. On the bottom right, I'm sure you all can see there's a little lesion. Kind of looks like the head of a cauliflower. All of the tissue surrounding it is normal bladder, but that little rounded area, that would be a bladder tumor. And, typically when you see something that looks like this, and most urologists will agree, the likelihood of this being a bladder cancer is exceedingly high. It's very rare to see something like that comes back as a benign lesion. So all the more reason to be proactive and expedite the workup process. We'll quickly touch base on this. This is a little bit more detailed, than we need to really go into, but the stage of bladder cancer, it's very important. Bladder cancer as a whole has a high propensity for recurrence and progression. So recurrence means, let's say we find a tumor, it's removed, has a high chance of coming back. Progression means going from more superficial tumors to invading more deeply into the bladder wall. So on the left-hand side, you can see the blue would be the most inner layer of the bladder. That's kind of where the urine, it's the part of the bladder that faces the inside. And you can see there's different type of tumors and staging you can have. So this first tumor that's kind of in the blue area, it can be either CIS or TA. And those are just kind of superficial tumors. And then as you kind of progress, you can start going layer by layer, deeper and deeper and deeper. And the big distinction happens between T1 and T2. And that's where you get that differentiating factor between non-muscle invasive and muscle invasive. And the importance of that is that it's a completely different type of treatment modality and pathway and algorithm that's undertaken for muscle invasive bladder cancer as opposed to non-muscle invasive bladder cancer. And then on the right hand of the screen, just another kind of diagram that shows you can have superficial tumors, and then you can also have tumors that start to invade more deeply through the layers of the bladder into the muscle, into the surrounding fat. And once you get to stage 4, those are tumors that have kind of penetrated through the entire thickness of the bladder wall. In males, they could invade into the prostate, the rectum, which sits behind the bladder. They can invade into the two tubes that you see coming into the bladder, which are the ureters that drain the kidneys. In a female, these tumors, if they're that advanced, they can start invading into the uterus, into the vaginal cavity. So those would be very, very delayed presentations. In general, bladder tumors, bladder cancers can be also categorized as high grade and low grade. Low grade, obviously, as it's suggested, they're less aggressive, less likely to recur if you remove them, and less likely to progress into a more invasive type of bladder cancer. High grade tumors have a much higher risk of recurrence and progression. So, for example, if you did not do any treatment at all, tumors that are T1, which means they're invading into that lamina propria or that second layer of the bladder, they have a recurrence rate of, at up to 80% within 3 years. And half of them can progress into more invasive type of bladder cancers within 3 years. So very, very important. Bladder cancer is a very aggressive cancer. It's not something that should be taken lightly. But on the other side of that, if caught early, if evaluated early, if diagnosed properly, and you're seeing a urologist that has good experience with managing and treating bladder cancer, it's a very, very, very treatable disease. And we'll talk about some of the treatments. Main thing is something called BCG, and we'll kind of talk about that here in a little bit. So, surgical, non-surgical treatments, once again, it's going to be determined by whether you have muscle invasive bladder cancer or non-muscle invasive bladder cancer, like we talked about earlier. But in general, surveillance and or treatment, they're extremely important, like we talked about, because of the high risk of recurrence and progression. So kind of like we talked about earlier, for a non-muscle invasive bladder cancer, whether it's muscle invasive or non-muscle invasive, the initial procedure that's done is something called a TURBT. And that's a fancy word for something that stands for transurethral resection of bladder tumor. And that's where we take a camera scope into the bladder. And I'll kind of come to this picture here just so you can talk about it. It's a resectoscope is what we call it. It's a specialized form of scope that goes through the urethra in a male or a female, that goes all the way into the bladder. And on the bottom left here, you can see this picture. This tool projects out of that we can control as urologists, and there's a little loop at the end of it. It's a loop that can cut and remove the tumor as well as cauterize. So we basically use that U-shaped loop. We use some electrical current to kind of shave these bladder tumors all the way down to the base. And our goal is to remove as much, if not the entire tumor, as possible, because sometimes removing the tumor in itself may be treatment enough, depending on the grade and stage of bladder cancer it ends up being on final pathology review. So some tumors are very, very large. They take much longer to remove. They can bleed a lot more significantly. So there are situations where people with really large bladder tumors, if for some reason there was too much bleeding, or the patient was under anesthesia for a long time, they may need a secondary procedure to come back to fully resect that tumor. But once you remove the tumor, that's when the pathologist will give us a diagnosis, whether is it invading into the muscle or not. And if it's non-muscle invasive, a majority of cases, if it's a high grade but not invading into the muscle, The most commonly used treatment for those patients is something called intravesical therapy, which is a fancy word for medicine that goes directly into the bladder. BCG is the most common form of intravesical therapy that's used, and it's a fancy word. It's basically an attenuated mycobacterium that is instilled into the bladder, and it's a form of immunotherapy that stimulates your body's own immune response against the bladder cancer cells. That's the most commonly used intravesical therapy. There are some chemotherapy agents that are used as well. And typically, it's done initially for a course of 6 weeks. So the patient would come into the office, we place a catheter into the bladder, and then we instill the medicine. Once the medicine is instilled, the patient will go home, keep it in the bladder anywhere from 45 minutes to a couple of hours. And then they'll urinate that medicine out at home in their bathrooms. And there's a few precautions that we will let you know of to make sure everything is done properly. And usually that's done once a week for 6 weeks. And then the most important thing with all bladder cancers is surveillance. Because these cancers, despite treatment, have such a high risk of recurrence, we typically, for the higher grade, higher risk patients, will typically do cystoscopies in the office every 3 months for the first 2 years. If you have a lower grade or less aggressive type of non-muscle invasive bladder cancer, that interval may be spaced out to 6 months or sometimes even once a year. But typically, these patients are followed for anywhere from up to 5 to 10 years because it is a serious condition that can recur and that can progress. So we want to be very diligent in doing all of our evaluation. So that's kind of treatment in a nutshell for non-muscle invasive bladder cancer. For muscle invasive bladder cancer, that's the kind of tumor that's invading into the muscle. It's a whole different treatment strategy because it's a much more aggressive, much more invasive type of cancer. That typically involves removing the whole bladder, which is a big undertaking. It's a major operation. It's done by a few of our partners, but more so done in more academic institutions, and requires a lot of care, perioperative care, long recovery. And we won't go so much into that unless there's any questions about that at the end of the session. But bladder removal is a big undertaking. A lot of times these patients will also get systemic chemotherapy before the surgery. There are situations for muscle invasive bladder cancer where we may not remove the whole bladder. Patients that are poor surgical candidates, patients that have had an invasive tumor, but it's very small or localized, or patients that say, hey, no matter what, I'm not losing my bladder. In those situations, we would aggressively resect the tumor as much as we can endoscopically with TURBT, like we discussed. And then in addition to that, they would get systemic chemotherapy, and then our radiation oncologists would administer radiation therapy to the bladder. Those have less likelihood of long-term cure. And in general, 50 to 60% of those patients will recur and may require bladder removal down the road, but that is a potential alternative option. And then once you start getting into metastatic disease or more advanced diseases, there are some systemic immunotherapies, targeted therapies, clinical trials. A lot of these will be facilitated with oncologists as well as some of our urologists. So we won't spend too much time on that. This is once again the drawing we saw earlier. In terms of advances in bladder cancer care, every year new therapies are coming out. There's a few new FDA-approved therapies. These are bladder installations like BCG that are used for patients who may not have responded to BCG well, their cancer recurred. Keep in mind the high-risk bladder cancers, despite BCG therapy, studies have shown that those patients can recur in 30 to 40% of cases. So there are patients that either don't respond well to BCG or they're intolerant, meaning they have a lot of side effects that don't allow them to continue treatment with BCG. So these are a few medications, Anktiva and Inlexzo, Adstiladrin, Zosturi. Those are for certain subsets and populations of bladder cancer patients that can be considered in later stages. Also, patients that may not have responded to BCG, who may not be candidates for some of the bladder installations, there are some systemic infusions that are also FDA approved, like Keytruda, which you may have heard of for other cancers. In terms of advances in surgical technique, Most of the TURBTs and the initial diagnoses are all done endoscopically without any incisions or cuts or anything like that. If you do happen to be one of the patients who unfortunately has muscle invasive bladder cancer and needs to have their bladder removed, we have so many new minimally invasive techniques. The picture there you see there is the Da Vinci robot, and it allows us to remove the whole bladder with just few small incisions, whereas even 5, 10 years ago, we would be making big abdominal incisions to remove the bladder. So this significantly, speeds up recovery, return to bowel function, much more precise, less blood loss. So it's just something of note to mention that there are minimally invasive ways to remove the bladder should you fall into that subset of patients that needs that treatment. There is something called blue light cystoscopy that can be done in certain patients, and basically, it's a specialized cystoscopy that uses a special molecule. It's called Cysview as the brand name for it, that's instilled into the bladder before the procedure. And then you place a cystoscope just like you do in the office. And what happens is the cancer cells that may be in your bladder, they'll absorb that medication. And then you turn on the blue light setting through the cystoscope. So on the left side is a regular white light cystoscopy that most of us do. But when you turn on the blue light in a patient that's received this medication, you can see this area that fluoresces or glows this kind of pinkish reddish color. And if you look under the white light, that area, is not as apparent. So the helpful scenarios for blue light cystoscopy is if you have small flat tumors, and those are typically called carcinoma in situ or CIS. If you have a positive urine cytology, but when we do the camera scope under white light, if we don't see anything that looks abnormal, this is a situation where the blue light cystoscopy would be useful. So it can help detection of small tumors. It can help reduce missed tumors. It can help lower recurrence rates. So it's just one consideration I wanted to bring up. There's a couple of new tests that we're using in some of our patients. Vesta is a company that makes these two tests, BCG Predict and Risk Stratify high grade. And it's, simply put, it's a histologic assay that uses the biopsy slides from the TURBTs that we do. And it uses artificial intelligence to provide insight into things like risk of recurrence of the bladder cancer, risk of progression, and this is an important one, is the likelihood that a patient may not respond as well to the BCG treatments, which is widely accepted as the standard of care or first-line therapy for most non-muscle invasive bladder cancer. So there's a few tools that are coming out that we're utilizing that can help us, that help complement the traditional staging that we do, like we previously discussed, but also help us make more individualized decisions in terms of what intravesical therapy might best suit certain patients compared to others. So, in general, what can patients expect from diagnosis, treatment, follow-up care? So before treatment, when you see one of our urologists, we're going to give you a clear explanation of the diagnosis. We're going to discuss all of the options, and we kind of briefly went through everything. It can be overwhelming. So our job as providers is to kind of break it down, to tell you what your risk category is, what type of bladder cancer you have, and then what options make the most sense for you, whether it's a standard of care BCG, all of the alternative intravesical therapies we offer, whether it's just simply surveillance. Some people with low-grade small bladder tumors, they may not need any treatment, but they do need surveillance. And we kind of go through all of that. And essentially, it's shared decision-making to make sure everyone's on the same page and feels comfortable with their treatment plan. During treatment, we monitor you closely for your symptoms. We will do cystoscopies at routine intervals, depending on the type of bladder cancer that you have. And, if you do have certain symptoms that are bothersome, we help manage those symptoms with various medications, and, there's regular follow-up. And then after treatment, once again, like we talked about, we'll be getting to know, we and you will be getting to know the inside of your bladder very well. With cystoscopies, we'll do imaging of the urinary tracts, because once you develop a bladder cancer in the bladder, it can always arise in other parts of the urinary system, like we talked about earlier, whether it's the kidneys or the ureters or the urethra. So it's very important for us to uh, fully evaluate you with imaging and cystoscopies. And then, we're going to be focusing on your long-term quality of care. If this treatment is going to significantly have an impact on your quality of life, we talk about alternative strategies or what we can do to help make sure that the quality of care and quality of your life are valued. In terms of recovery time outcomes, it varies by the stage of bladder cancer you have, the type of treatment. Early stage bladder cancer has excellent outcomes as long as it's detected and treated promptly. Many early stage patients, they return to normal life pretty quickly. The more muscle invasive cases where their whole bladder has to be removed, they require more recovery time. Once again, our focus is long-term health, quality of life. I can't stress this enough. Long-term follow-up is very, very essential because the high risk of recurrence for bladder cancer. Once again, when caught early, bladder cancer is very, very, very well treated. What to expect? This is pretty self-explanatory. All your information is going to be confidential. We'll treat you with respect. We do a full evaluation with using all of the current AUA and NCCN cancer guidelines. We have all the latest tools and techniques and tests and treatments. And our job is just to open that discussion with you and give you all your options and come to a decision that makes the most sense for you and that you feel comfortable with. So with that, we'll kind of come to an end there. Some common concerns before we open up the floor. Is blood in the urine always cancer? No, it's not always cancer, but it's certainly going to set off a red flag. And like we talked about, patients that get diagnosed with bladder cancer, up to 30 to 40% of them will have blood in the urine as a presenting symptom. Is bladder cancer curable? Absolutely can be, depending on the stage, how early it's caught, what sort of treatments are administered. Does smoking really increase risk? Absolutely. There's no ifs, ands, or buts. It's just one of the biggest preventable risk factors for bladder cancer. Side effects of BCG, usually it's going to be just irritative urinary symptoms, frequency, urgency, some dysuria or burning with urination. Some patients can get low-grade fevers because it does stimulate your urinary system. Your immune system against your bladder cancer cells. So those are some common side effects. And some people will have more significant side effects that we can manage, or if they're intolerant of that, that's when we would transition to different types of therapies. Lastly, how often will I need follow-up? The short answer is it's going to be a very close surveillance protocol. It could be as early, as short as every 3 months in terms of doing camera scopes for up to 2 years, or it could be annually for up to 5 years. But it all depends on the grade of your bladder cancer, the stage of your bladder cancer, and what kind of therapy or treatment you received.
Awesome.
And I will pause there and give it back to Jamie.
Yeah, we have several questions coming in, and if you haven't submitted your questions yet and you have one, be sure to go ahead and do that at the Q&A button at the bottom of your screen. But here's some great questions. So one is smelly or fishy urine a sign of bladder cancer as well?
Not necessarily. It can be. If you have a bladder tumor that's necrotic, I have seen patients that that just ignored their symptoms for a long time, had blood in the urine, and then when I do the camera scope in the office, you just see this large necrotic type of bladder tumor. Those can have fishy smell, foul smelling type of symptoms, but it doesn't necessarily mean you have bladder cancer. But if you notice anything unusual with your urinary habits, call us, make an appointment, and we can quickly find out if there's anything to worry about.
Awesome. This one is a question kind of related to symptoms or determining if you have a symptom, but do you recommend Regent strips to detect blood at home?
Not necessarily. I think the best way to detect blood in the urine, a lot of in our office, when we do an initial dipstick, sometimes that may show traces of blood, but the only true way to diagnose blood in the urine is done for blood that's not visible, that's microscopic, is to do a microscopic urinalysis where we look under the microscope, and that will give us the best way to determine if you meet the threshold or the criteria for workup.
This is a question from a gentleman. He's asking or stating that he's had multiple prostate procedures and that he read or heard that this can lead to virtually no emissions during orgasm and that the semen travels into the bladder. Is that correct? And is it a contributing factor for bladder cancer?
Yeah, so a lot of people that have prostate procedures for benign enlarged prostates, there's a handful of them that can cause a side effect called retrograde ejaculation. And essentially, that semen that's ejaculated during climax will fall back into the bladder. That will not increase your risk of bladder cancer. It's a normal physiologic side effect of certain prostate procedures. And that semen usually will mix with the urine and patients will void it out. But it's not going to, that semen is not going to increase your risk for bladder cancer.
This is along kind of the same lines, but asking how likely is it for prostate cancer after the prostate is removed to go into the bladder?
So those are two separate processes. If your prostate is removed for prostate cancer, there's typically no link between that and the development of bladder cancer. That being said, I do have patients who have simultaneous prostate and bladder cancers, but those are different processes, and those are both managed differently. Simply removing the prostate for prostate cancer will not increase your risk for developing bladder cancer.
Thank you. How is it determined whether it is a high grade or a low grade cancer?
So that is determined, once again, if we do a clinic cystoscopy, we find a tumor, then we take you to the operating room and do that procedure called a TURBT, where we scrape and remove the entire tumor. All that tissue is then sent off to the pathologist, and they're the ones that are skilled and trained to look under the microscope, look at various stains, look at specific histochemical findings that allow them to give a certain tumor status of high grade or low grade, and then that's the information we use to help figure out what treatment is best for you.
So, there's a few questions here, several in fact. So I'll kind of follow these up one after the other. But one of the questions is, what happens after a bladder is removed?
Yeah, so if you happen to fall into that subset of patients that have muscle invasive bladder cancer, that requires removal of the bladder. As you know, the bladder is a storage organ. It stores your urine until it's full, and then you evacuate it. So when you remove the bladder, we need to divert the urine. That's called a urinary diversion. And historically, there's a few different ways to do that. The most commonly done procedure is something called an ileal conduit, where essentially most patients have probably heard of a colostomy. It's similar to that, but it's called a urostomy, where we take a small segment of your small intestine, and then we divert the ureters, which drain the urine from the kidneys, and we connect them into a small segment of small intestine, and then that's brought out typically on the right side of your abdomen, and it's called a urostomy, and that'll just freely be collecting urine into a little bag. That's called an ileal conduit. There's something called an Indiana pouch, which is a similar concept, but it's a little pouch of basically a neobladder that's made inside the belly using intestine. The kidneys are similarly connected into that. And then there's a little opening in the skin called a stoma. And this is a continent diversion, meaning it doesn't constantly leak urine. And in order to empty that pouch, you slide a catheter through your abdominal wall into that pouch several times a day, and that'll drain the urine. There is a third form of urinary diversion. This is going to most mimic normal physiologic anatomy. It's called a neobladder. And it's a very highly specialized form of urinary diversion. There's a lot of criteria you have to meet in order to qualify for it. But you basically use the intestines to create a bladder, a new bladder inside the pelvis, and then you reconnect that to the urethra. So when someone is looking at you, they would have no idea that you had any sort of bladder cancer or any, aside from the surgical incisions. And the way that works is it will similarly fill up like a bladder, but it's not going to have the same nerve innervation. So you're not going to know, hey, my bladder is filling up, you're not going to get that similar urge to urinate. So most people typically, every few hours they'll go to the restroom, and it mimics the most physiologic normal way of urinating, but it's still not going to feel like a normal bladder. A lot of times to help empty that neobladder, you have to do something called a valsalva or bear down or increase abdominal pressure, and that helps facilitate emptying of that neobladder. But that's a great question. When your bladder is removed, it has to be diverted. There's a few different ways we can do that.
So that covered several questions, and someone even asked about the neobladder. So that was great. Thank you for answering that. One of the questions is really what are common ages in both men and women, or are there common ages where bladder cancer becomes more prevalent?
I wouldn't say there's any specific age. In general, you tend to see bladder cancer in older patients, and there's a clear correlation with increasing age and developing bladder cancer. Most of my patients, I would say, that have bladder cancer are going to be in their 70s and 80s. I have a handful of patients in their 60s. I do have a few patients in their 40s and 50s. That's much less common. But it just goes to show you bladder cancer can occur. I know some of my partners have patients in their 30s that were diagnosed with bladder cancer, although that's much more rare. Which kind of once again goes back to my point is if you see blood in the urine, whether it's one drop or anything at all that looks abnormal, you start having a sudden change in your urinary habits, just call us, get evaluated. It's very, very simple to get tested and figure out if there's anything concerning going on.
Okay. That covers one of the additional questions is if there's no blood in the urine, you've talked about some of the symptoms, but any other key symptoms to look for?
No, like I said, about 30% of patients, 30 to 40% of patients with bladder cancer will have visible blood. 10 to 15% will have microscopic blood. A lot of patients will have irritative voiding symptoms, frequency, urgency, burning. But those are typically the common symptoms. And in more advanced stages, like we discussed earlier, you can have pain or pressure in the pelvic area. If it's advanced to the point where it's blocking the kidneys, you can develop back pain in more advanced stages.
One other question is if a family member has had bladder cancer, is there a likelihood that other family members will get bladder cancer as well?
Family history can be a risk factor. It's not the most important risk factor. People that have family history of bladder cancer, they should just be more diligent. They don't need to go and get genetic testing right away or, see a urologist starting at age 35, but, just be cognizant, be aware of your body. If you notice any of the concerning symptoms we talked about, certainly let us know. When you see your primary care physician on an annual basis, make sure they're aware that you do have a family history of bladder cancer, just so they're aware as well, because they're the ones that are going to be doing the once a year urine test. And if anything shows up on their end, they'll be more likely to pay attention to abnormal urine results, and that would lead to a quicker referral to see me or one of our urologists, so we can stay on top of it and detect things early if there is something going on.
We talked about smoking and that being really important to put aside, but there's a question about marijuana as well. Is that a similar concern?
No, it's usually tobacco exposure. To my knowledge, I don't know of any long-term risk of marijuana. I'm not saying there isn't to the development of bladder cancer.
There's a couple of questions here about the TURBT. So
Yes.
if flank pain returns 6 weeks after, is that a bad sign?
Flank pain after a TURBT. So there are situations where the tumors can be in close proximity to the openings of the kidneys where the ureters join into the bladder. In certain situations, we do those tumor resections in close proximity to those areas. The risk or the concern if you had flank pain, in the weeks after a TURBT is, did something during the biopsy procedure, sometimes if you cauterize close to that area, there can be swelling or inflammation that can temporarily block that opening. And in that situation, the patient can develop swelling of the kidney. which in turn can lead to flank pain. So that's a consideration. If you develop anything like that, let your urologist know right away so we can get some imaging and see if there's something going on.
Another question here is, should I avoid wine or beer after TURBT?
Wine or beer after TURBT, aside from the effects of, the immediate effects of anesthesia and drinking alcohol can make you extra drowsy, I don't have a strong preference as to, stopping drinking wine or alcohol. Use your judgment.
Another question here is, does diabetes or weight have anything to do or play a role in bladder cancer?
Not directly, but diabetes and obesity are in general just risk factors for a multitude of health concerns that can lead to other issues down the road. But diabetes and obesity directly, do not have any direct link to increasing the risk of bladder cancer, aside from just not being healthy overall.
Yes. Another question is, if I'm over 50 and I don't have any symptoms, should I still come in and be evaluated for my urologic care?
Absolutely, I think you should be. So, we bladder cancer is one of the 100 things that a urologist evaluates. So, once you turn 50, all the guidelines recommend routine PSA screening, which would be for prostate cancer. So, it's always good to just set up an appointment with a urologist. We can talk about, prostate cancer screening. We would evaluate your urine to see if there's anything concerning in the absence of symptoms that may warrant further workup. We can talk about your sexual health. There's just so many things that we can do in that initial consultation. So absolutely, it's a good idea to get set up with a urologist around that age.
Let's see what other questions we have here. So if you have had no recurrence of bladder cancer after 13 years, are you safe from reoccurrence?
The short answer is you're never 100% safe. But like I talked about earlier, typically, if you had a good success to initial treatment, we typically follow patients anywhere from 5 to 10 years, with a strict surveillance protocol. After 10 years, if they've been disease-free, no recurrences, otherwise doing fine, then we just, we have a frank discussion in the office. And, some patients say, hey, I don't care, about having a scope done once a year, so let's keep doing it. Some patients will just do cystoscopies once a year, indefinitely. Some patients, we may do it every 2 years. Some patients say, hey, I hate cystoscopies. I'm at the 10-year mark. I'm asymptomatic. And those patients, as long as we're understanding of the potential risks, we'll just still follow them at least once a year, just to keep an eye on their urinary symptoms. We may check urine cytology testing. That way, it's a non-invasive way to still kind of keep tabs on what's going on. And if anything, sets off a red flag, then we go right back into the full initial workup.
Well, does a long history of UTIs increase risk of getting bladder cancer?
It can, that's, I don't have a strong answer one way or the other for that. But kind of going back to what I said earlier, chronic UTIs can cause chronic inflammation. And the thing about that subset of patients that have chronic UTIs that are having persistent, most of them are seeing a urologist. If not, you should be. And in those patients that get referred to me for chronic UTIs, we do a full workup. I would recommend a cystoscopy and imaging of the kidneys for other sources. And in that workup, if there is something going on, bladder cancer wise, we would find it.
Another question is, if the bladder wall is thickened, what is the chance of developing bladder cancer from that?
Thickened bladder wall does not have a correlation with the development of bladder cancer. Thickened bladder wall is usually seen commonly in males that have enlarged prostates, and it's just a function of how the bladder muscle hypertrophies, and just because it has to contract harder just to get the urine out. There's other situations that can cause thickened bladder wall, but that by itself is not a risk factor for developing bladder cancer.
Okay. Well, another participant is asking or stating that they seem to notice they pass more blood after eating a bunch of sugar. Is that a coincidence, or should they come in and get that checked out as well?
I don't know of any direct link between that. It certainly is a possibility, but if you're seeing blood in the urine, you need to call your urologist right away. So I would recommend give us a call. We'll get you in as soon as we can and initiate the workup. Blood in the urine is not normal, so we have to figure out what's causing it.
We have time for just a few more questions. If you still have a question and you haven't submitted it, be sure to submit it. We'll just spend a few more minutes and then we'll close out for the evening. But one of the questions we have is, can you talk about a new device known as the pretzel?
Yeah, so that's the Inlexo that I mentioned earlier, and it's basically it's a device that's shaped like a pretzel. It's used for patients that either did not respond to BCG or are intolerant of BCG. It secretes a chemotherapy medicine called gemcitabine. And we are offering that at Urology Austin. We have a team of bladder cancer experts, and it's inserted into the bladder. It stays in the bladder for a few weeks, then we remove it. And there's a certain surveillance protocol where we, look into the bladder at periodic intervals and reinsert the pretzel at periodic intervals. But it is a potential treatment for a certain subsets of high risk bladder cancer patients.
Let's see what else we have here. This is a great question. Do bilateral stents increase chance of bladder cancer because of irritation from the ends of the stents?
Not typically. A lot of patients have chronic stents for a multitude of reasons, whether they've had radiation for other cancers and developed strictures. But chronic stents absolutely can increase your inflammation just around that area where the ureters join into the bladder. But those patients with chronic stents, the positive of that is they have to be exchanged every few months, anywhere from 3 to 6 months. It's not like they're put in and forgotten about. And in order to exchange the stents, you have to take a look inside the bladder with a cystoscopy. So at that point, we would be able to evaluate those areas and see if there's anything concerning that's developed.
This is a question about, once maybe a low grade cancer is found, is the treatment really aggressive at that point to stop reoccurrence or from it progressing into more of a metastatic cancer?
Yeah, so if your initial tumor was a small localized tumor and the pathologist told us that it was a low grade and not invasive, there's a certain size criteria, but a majority of those tumors, if they're solitary, if they're small and superficial and they're low grade, we typically will just put those patients on surveillance and will not recommend any sort of treatment because they have a very low risk of recurrence and progression into more invasive types or higher grades of bladder cancer. So in those patients, we typically put them on surveillance and we'll do their initial cystoscopy after the initial diagnosis at 3 to 6 months. And then we may follow them every 6 to 12 months for the next 5 years. If those tumors ever come back or they become increasing in number or more higher grade, then we would recommend treatment for them at that time. But a low grade, small bladder cancer is the best kind of bladder cancer you can have.
Okay. And then I'll raise one final question and then we can close out for the evening. But what are the chances that a CT scan with contrast could miss bladder cancer?
Extremely high. And as I stated earlier, a CT scan is good for looking at the kidneys. It's good for looking at the drainage tubes of the kidneys, which are the ureters. Once in a while, depending on the phase of the study that's done, we might be able to find or see something that suggests a bladder tumor, but it's not great. So that's why we recommend doing the cystoscopy. That, in my opinion, and most urologists will agree, that's the most important test to detect a bladder cancer in any patient that's undergoing workup.
Well, great. Do you have any final thoughts for us tonight, Dr. Shatagopam?
Yeah, thank you everyone for joining us. I hope this was informational and informative. Just, bladder cancer is common, but like I said, time and time again, early detection makes all the difference in the world. If you notice blood in the urine, just do not ignore it. If you notice any sudden changes in your urinary habits, do not ignore it. Just call us as soon as possible. We'll get you in for an appointment, and we can do all the necessary testing. We're here for you. Our job is to figure out what's going on, if anything, and if we do find something, provide clear answers, give you all the latest treatment options, and just personalize those to your specific case because everyone's bladder cancer can be different.
And how can
That's
someone,
all. Oh, sorry, go ahead.
I was to say, how can someone make an appointment with you or others?
Yeah, you can call this number that you see on here. You can go to urologyaustin.com. You can make an appointment through our website. Myself, I go to the Georgetown office, the Round Rock office, and the Atrium office, which is in the North Austin area. Um, if you go on our website, we have a bladder cancer section. If you want to do some more reading about it, it'll give you just a brief overview. You have this webinar that hopefully, was useful for you, but, just do not hesitate to call us any red flags, anything that just doesn't feel right in terms of urinary symptoms, blood in the urine, just call us. We're here for you. And we want to catch things early so we can give you the best possible treatment.
Awesome. Well, thank you so much, Dr. Shatagopam. Great content. Thank you for taking your time and sharing your expertise. And thank you for all of our participants tonight. Have a great evening, and we'll see you next time.
All right. Thank you, everybody. Have a great night.